Today's objective is on abdominal and pelvic masses. So the objective starts with this. It says that abdominal or pelvic masses may be noted on physical examination or discovered incidentally on imaging. All right. It is imperative, that is a very critical word, for a physician to determine which masses require immediate investigation and treatment and which one can be safely monitored. It is imperative. Okay, so those words are very critical. Now, when I reviewed that objective, I realized that for you to say that you finished this objective, you should have reviewed 32 topics in just one objective. 32 topics. And why do I say that? I'm going to show you why I say that. So this is a very loaded objective. So when you're dealing with this objective, please make sure that all 32 topics are covered. Number one, you need to cover gastrointestinal tumors. So you need to cover colon cancers, liver cancers, gastrointestinal stromal tumors. Those are 3 already. Then you need to make sure that you've covered hepatitis, you've covered pancreatitis. And when you're covering pancreatitis, please write it down. Write that you're going to cover both acute and chronic pancreatitis. And then like pancreatic pseudocysts as well. And you need to do, ovarian cancers, uterine cancers, kidney cancers, bladder cancer, prostate cancer as well. Doctors, please, are you seeing why I'm saying that this is a very extensive objective? Then ovarian cyst, ectopic or normal pregnancy, and leiomyomas, that is fibroids, must also be covered. And then you need to also cover hydronephrosis, renal cysts, urinary retention, benign prostatic hypertrophy. And then you need to cover splenic tumors, leukemia, lymphoma, infectious mononucleosis, which is also found in the last objective. It is entitled Approach to White Blood Cell Count Abnormalities. That is the last topic in the MCC objectives. It can appear in both this objective and then the approach to white blood cell abnormalities. So we've already covered that. So when you're studying this, you don't need to worry so much about that. Then you also need to get into malaria, sickle cell disease. And malaria is also covered under infectious diseases as well. So you realize that some of the objectives cross over. And you may ask, why should we cover malaria as part of abdominal and pelvic masses? Don't forget that malaria can lead to hepatomegaly. So that is why some of these things are there. Doctors, please, are you getting it? So please, these are the topics you need to cover. It is until you've covered these topics that you can cross it in your study portal that I have covered this particular objective and I'm done with it. If you've not done that, please, you've not finished it at all. Okay. And there are more: adrenal cell tumors, pancreatic tumors, neuroblastoma, abdominal aortic aneurysm, sarcoma, and lipoma. So these are the 32 topics I was talking about. So the key objective is this: given a patient with an abdominal or pelvic mass, the candidate will complete a relevant history, physical exam, and other pertinent investigations to determine the most likely diagnosis, all right? And the candidate will initiate an appropriate management plan. So with all those 32 topics I listed, make sure that whenever you are learning, you ask yourself, what am I going to ask on history, physical exam, investigations, most likely diagnosis, differential diagnosis, appropriate management. And in particular, the candidate should recognize the features of a mass and any associated findings that indicate the need for immediate intervention. So whether it is lymphoma, whether it is uterine fibroids, whatever it is that you're dealing with, make sure that you look at it in the context of relevant history, physical exam, investigations, differential diagnosis, appropriate management. That is emergent management and follow-up management. That is the approach we want you to use so far as MedCognito is concerned. Okay, good. So now let's get into the enabling objective. So given a patient with an abdominal or pelvic mass, the candidate will, number one, list and interpret critical clinical findings, including systemic symptoms and signs related to the mass, like weight loss, hypertension, menstrual irregularity, and result of an appropriate physical exam aimed at determining the likely cause of the mass. List and interpret critical investigations, including laboratory and imaging tests. For example, ultrasound, CT of the abdomen and pelvis, tumor markers, and construct an effective initial management plan, including determining whether the patient requires immediate intervention or referral to specialized care, determining whether the patient requires serial monitoring. So that's why they've put in there. For example, if you have a patient with renal cyst, you want to do serial monitoring for that particular patient. So now, with all those 32 topics, I want us to pick one of them and really, really make sure that we break it down, because this is a very, very important topic. And it cuts across gastroenterology, it cuts across abdominal masses, It even has some radiological implications. It has some surgical implications as well. So, and even endocrinological. So this particular objective cuts across various systems. And that is why you realize that, like in the Canadian medical exam, the MCCQE1, they don't just say, go and learn these systems. Rather, they will give you approach to this, approach to that, approach to that. And then one approach can lead you in about 5 different systems. Okay, good. So we're going to start by reviewing the causes of acute pancreatitis. Because when you talk about pancreatitis, and whenever I'm dealing with a lot of candidates, that is what I really realize. Everybody's talking about, I get smashed, I get smashed, I get smashed, I get smashed. But this particular objective is telling us that there's more beyond I get smashed. So let's start with where candidates are very familiar with. If we want to know the cause of acute pancreatitis, we need to know I get smashed is one of the commonest acronyms everyone preparing for the MCQ1 exam should know. So that is idiopathic. It can be caused by idiopathic concerns, gallstones, alcohol or ethanol, tumors like pancreatic tumor, ampulla ovata tumor, polydoku cells as well, scorpion stings, can you imagine? Microbiological, like some infections as well, autoimmune conditions, surgery, trauma, hyperlipidemia, emboli into the, like maybe a pancreatic vessel, emboli and ischemia, and drugs and toxins. So, as I said, almost everyone learning pancreatitis will have to learn this acronym. But the point is, beyond this, I get smashed that everyone knows. What are the nitty-gritties of acute pancreatitis that we need to know? Number one, because next year the exam format is changing. It's going to be just MCQs. And when it comes to MCQs, it looks like you need to have deep knowledge, not just broad knowledge. Broad knowledge is good for CDMs, but if you want to ace MCQs very well, you need to make sure that you have very deep knowledge. So I've decided that henceforth, all webinars we do, we make sure that we cover everything and we don't leave anything to chance, because MCQs are MCQs. You can be quizzed on anything so far as this exam is concerned. So looking beyond I get smashed. Because yes, for CDM, if I ask you, patient comes in with epigastric pain, patient has a history of gallstones, amylase levels and lipase levels are elevated. What are other etiological causes? You can use I get smashed to look at it. But beyond I get smashed, now that we are going into only MCQs, what are some nitty-gritty things you want to know? Number one, the 2 top causes of pancreatitis are gallstones and chronic alcohol use disorder. Gallstones and chronic alcohol use disorder. I remember one of the videos, and if you go to our YouTube channel, which I've talked about, and you can see the link in the comment section, I quite remember that we've discussed the issue of hepatitis and how you're going to use, ALT and AST to help you to determine whether this is alcoholic hepatitis or not. So now that we are learning that the 2 top causes of acute pancreatitis are gallstones and chronic alcohol use, you want to ask yourself, okay, how will I be able to use labs to be able to tell? Okay, now, even with these 2 as the 2 commonest causes, gallstone is the most common cause of acute pancreatitis. So please write this one down. It's not enough to know I get smashed. It is rather even more important to know of all the components of I get smashed, which of them is the more likely cause of pancreatitis, and it is gallstones. Gallstones. Okay. Let's review the history, and then I'll get to the next point. So now that we've looked at the various etiological causes, we've looked at the top two causes, alcohol and gallstone, but we've learned that even with alcohol and gallstone is the highest. What are you going to ask on history? Because I can ask you in a CDM case, hey, patient has come in with this, you suspect acute pancreatitis. What historical questions would you ask? Okay, so that is another thing I want us to get into. So these are the historical questions you want to ask. Let's go straight to the point. Number one, does the patient have a history of gallstones? Number two, has the patient had a previous ultrasound image confirming the presence of gallstones? Number three, has the patient had to make any emergency room visits for right upper quadrant pain and a diagnosis of biliary colic? Number four, does the patient have any history of unexplained weight loss? And in getting to the latter part of the class, you'll understand why unexplained weight loss and pancreatitis can go hand in hand. Has the patient had any new onset of diabetes? That's also something I want you to. So new onset of diabetes plus pancreatitis should cause you to start thinking about something. Unexplained weight loss plus pancreatitis should cause you to start thinking about something. Does the patient have any history of alcohol use? If yes, what is the pattern of alcohol use? Some authorities say that most of the time the patient should have used alcohol for more than 5 years for you to start seeing that alcohol is a serious risk factor for their pancreatitis. Okay. And then medication history. So you want to ask about the use of aminoglycosides, the use of diuretics, sulfonamides, valproic acid, estrogen. And you realize that each of these medications and their effect on pancreatitis, they have different mechanisms, but that is too highfalutin for this exam. The only thing is that you want to know that some medications can cause pancreatitis, and all you need to know is that the examples of some of the medications like aminoglycosides, diuretics, sulfonamides, valproic acid, estrogen. All right. And then surgical history. Has the patient had any prior abdominal surgery? Has the patient had ERCP, that is endoscopic retrograde cholangiopancreatography? And has the patient had any abdominal trauma? As well as, does the patient know or does the patient have a record of hypertriglyceridemia or hypercalcemia? And then, is there a history of autoimmune disease suggestive of for autoimmune pancreatitis? And is there a family history of recurrent pancreatitis, or even is there a family history of pancreatitis itself? All these questions we are asking on history will become very relevant if we start diving deep into the case itself. And then, has there been any history of childhood pancreatitis without any cause? Because that should prompt you to start looking at genetic concerns, right? Is there a family history or is there a personal history of pancreatic cancer? So these are the things you want to know on history so far as a patient with pancreatitis is concerned. I just want it to sink in, and then we'll move to the next step. So since we just talked about history, how will the patient present? Typically, you realize that the patient will present with acute onset of severe upper abdominal pain, or epigastric pain. This is associated with nausea. This is associated with vomiting. This is associated with abdominal tenderness on palpation. The patient may have fever. The patient may have tachypnea. The patient may have tachycardia. The patient may have low oxygen levels like hypoxemia, and the patient may have hypotension. A lot of these factors will also help us to determine the severity of the pancreatitis. So please note that very well. We've learned about questions to ask on history. We've also looked at how the client will present if they should come in with acute pancreatitis.